Our next presenter is my co-chair, Knud Yderstræde. And Knud is going to look at how telemedicine has been implemented in Denmark. And the title of his presentation, The Process Towards National Implementation of Telemedicine in Wound Care, the Case of Denmark. Thank you, Knud.
Thank you, Catherine. I would like to bring forward some of the issues that we encountered during the process from this project that we did in diabetic encountered everywhere in Europe and maybe in the whole world. So I'm just going to share some of the aspects that I think you should look into when you're trying to do this evaluation and put it into a broader space. Some of the key messages I would put forward is, of course, it might sound a little bit trivial, but you should place the patient in the center before you even start thinking of the technological solutions. We have a huge amount of industrial personnel that wants to forward a number of new technologies, but we have to keep the patient in mind. Some of them want face-to-face consultations and so on. We should be sure from the very beginning to integrate all partners in a multidisciplinary telemedical setup. We should decide what kind of evaluation to be performed. And as part of the EWMA eHealth group, trying to find out how we should work on this, I would strongly advocate that we use the MAST model. Please look into that and try to applicate that for your own systems. Also, you should bring in the authorities at a very early stage to ensure that you have the political and health supportive system. Sometimes there's a lag phase there. And what I would also like to advocate for is that you should have the patient in your consultation and stratify this patient. A lot of confounders, as you from the WSD study knows, these people are very sick. They have a lot of confounding morbidities that we have to take into consideration. Now, before we even started out, we had to establish a nationwide electronic platform. We did this by this database, which has now been encountered in all of Denmark, trying to solve the telemedical solutions, and also be applied to other telemedical or telecare situations. We try to keep it simple, but there, of course, there's a lot of facilities in this database, and we just wanted to have a day-to-day possibility of looking into a specialized patient like this one, where you have a nurse at the center of the patient's home taking a photo, which we try to optimize by this setup. Simple cell phone, an app to this phone, so they upload the pictures to the special center where we can look at these pictures and discuss with the nurse how to handle it. And actually, the quality of the photos have improved very much. I hope you will agree with me that as a clinician, you can look into this also, and you can give some good advice for the nurse directory of how to handle this also. However, it does take time to have a telemedical consultation, and there's, of course, an economical issue in that aspect. I'll just take you through how we consider a normal classical telemedical consultation. I would summarize the patient data and the electronic patient records. I would go to the photo documentation. I would look at resulting results from other intervening sections like the X-ray database that we use, of course, again. I would have the telephone contact with a specialized nurse and discuss the patient. It might be asynchronically or synchronically. Of course, we would prefer having it synchronically so the patient could talk to the doctor as well. Then we document, and finally I secure the medication of the patients, whether there should be an antibiotic or something prescripted. It calls for an extremely important thing, which is the education of key personnel in the primary and secondary health sector. If we do that in a proper way, we also secure the ownership to implementation, and that is really the heart of the problem. If you don't take ownership to this, it won't work. And of course, also we're used to the face-to-face consultations. We need some logistical changes that we've been facing, but I think that's a problem of simply sitting down and thinking things over. There's some technical aspects. Would the technique you're using be reliable? Is it correctly applied? As we encountered, there were huge problems with the photo documentation, bad photos, low quality photos, and so on. Also, look into the accuracy of the technique. Is it reproducible so that we can do it in Australia as well as we can in the northern part of Europe? The other aspect is, what kind of study are we going to do? Are we going to do non-inferiority studies just to show that this works and we might save some money in the long run? If we have a golden standard, which we usually don't have in this situation, we should use it, of course, to make comparisons. We should discuss the clinical safety. We do not want to discuss the matter of potential harm to patients, because that shouldn't be an option here, should it? I don't know. The technical safety, how do we handle digital breakdowns, updating and so on, and the everlasting problem of backup, loss of data and so on, that simply puts us down, so we have to do face-to-face consultations as well. Overall, I would like you to use the PICO criteria, which involves the patient, how the patient population is defined, how we intervene. In this situation, we use primarily photo documentation. Are there any comparators, alternative possibilities that we can sort of put this up against and see whether we have better possibilities in other setups? And what are the outcomes? The patient could be characterized by a number of factors, of course. Usually these are very often used, and the comorbidity and the Charlson Index often is used to encounter what kind of people we are dealing with. Talking about intervention, we could do it purely observational, or we could do medical or surgical intervention, and as most of us are doing, multi-specialty intervention, which compromises some of the details in these studies and really makes it complicated. The comparator, if there's a golden standard, we should use it. And I would say, in general, we are doing pragmatic studies here because we have very, very different ways of handling these kinds of people. So we would say treatment as usual, and that could encounter a number of different specialties, a number of different treatments, and so on. At this symposium, this meeting, you will hear a number of good ideas on how to treat ulcers, and you don't do that in all countries, right? And what about the outcome? As we just nicely heard from the World System Demonstrator study, there was a reduction in mortality, but we also had to look into morbidity and infection and combined endpoints and even cure in some few instances. So these could be some of the outcomes that we should measure. Then there is the political aspects. When I left Denmark, this was the Minister of Health. There's been some changes in Denmark during the last few years, so I believe he's still the Minister of Health. I haven't heard anything else anyway. So in Denmark, we have to discuss, and I believe you have as well, the need for a relevant payment for telemedical consultations. If there's not a relevant payment, it's not going to work. It's as simple as that. And there are quite a few people with a conceptual interest in telemedicine. I don't believe they should govern the way we treat these patients. We should always, as clinicians, be involved in the early stages. And the political demands, which is not really the case in Denmark, should mirror those of the patients. We have to do studies on patients, patient empowerment, patients' feelings about being involved in telemedical solutions before we start out that way. The patient perspective, thus, should be based on a differential admission, and a well-functioning telemedical solution would be preferably reducing the in-house days, as we also know from the WSD study. Yeah. When we talk about the industry, we have had a lot of talks to those people who are developing systems for telemedicine. They pick the winners and they kill the losers. So we would be better off if we try to tell them what we want so they can go in the correct direction from the very start. There's a long phase from idea to handing out the user inputs, design, risk analysis, and prototypes. And we know that these people work for money, and if they don't get value for their money very soon, they're going to stop the process. massive amount of data that we get from telemedical solutions is really treated the best way. We could use case report forms, we could use other electronic setups, and we should discuss the matter of data safety in these aspects, because we might use telemedical solutions around the world and discuss with each other. If there's a specialist in Australia, I'd like to ask for something, he might have the data on the patient, and we have to secure data that way. Also, sometimes we have a banking of biological material that should be secured as well. And I believe we should have independent statisticians and calculators to perform these statistic evaluations. Otherwise, we might look for something that we want to be correct and good, instead of having an independent statistician work it out. So I just end off again with my key messages. To place the patient in the center, be sure to integrate all partners, decide what kind of evaluation, and I strongly advocate for using the MAST. Anyway, find some indicators that you can use. Bring in authorities at the early stage, and stratify the patient population before you even start off. And even more important, I would say you should be open-minded and listen to the criticism and skepticism that is around these telemedical aspects. It's not just coming down as something from heaven, it's something we have to evaluate correctly. Thank you.
Thank you, Knud. Any questions from this presentation? I think is there a question at the back there? No. I think it's interesting that you mentioned that you need to get everybody on board to help with implementation of a plan. Do you think that, as in your experience, is telehealth part of an additionality, as Trevor was mentioning, or is it? Do you see it as mainstream, and how do we make that leap?
Could I have the last part again? Is it part of? Mainstream,
or is it an additional thing?
Well, I think, first of all, we have to agree on the words we're using. What is telehealth? What is telemedicine? What are all these aspects? And I mean, it's a mud. We cannot really define all these things. But I think, as you said, it's important to have everyone on board from the very start and create this ownership. Then I believe there's a mainstream, there's a way to go along.
It all helps with implementation.
Yes, that's right.
Thank you.